Finals SAQ46 Enhanced Recovery Fast Track Program. A 74-year-old patient is scheduled for a primary total hip replacement. A. What are the potential benefits of an Enhanced Recovery Fast Track program for this type of surgery? And B. List the preoperative, intraoperative, and post-op factors necessary for a fast track program in this patient. Examiner's report. 49.9% pass rate. Many of the principles of fast track status are now being applied to hip and knee replacement surgery. Some candidates misread the question and focused on anesthesia for surgery on fractured neck or femur. To pass the question, a very generic answer would have sufficed. The Board of Examiners felt that the pass mark should be high. Excluding the specific details specific to hip replacement surgery, the following basic principles of enhanced recovery form part of the model answer. What are the potential benefits of enhanced recovery program? This includes early mobilization, reduced post-op complications, especially cardiopulmonary, reduced length of hospital stay, reduced cost, and increased theatre efficiency. Additionally, for colorectal surgery, early recovery of bowel function, and decreased duration of ileus. Factors necessary for enhanced recovery program includes pre-op factors, appropriate patient selection, patient education and motivation delivered by multidisciplinary team, pre-op optimization, admission on the day of surgery, staggered admission if possible, use of carbohydrate loading with clear complex carbohydrate drinks. In case with diabetics, ensure optimal glucose control. Additionally, for colorectal surgery, avoidance of bowel preparation. Intraoperative factors include surgical technique that minimizes operative time and avoid drains, fluid management, targeted fluid replacement, tranexamic acid intraoperatively, prevention of PONV by avoidance of nitrous oxide, use of TIVA, and use of routine antiemetics. Use long-acting opioids sparingly, maintain normal thermia, use quick offset anesthetic agents to allow rapid recovery. Additionally, for total hip replacement, avoid urinary catheter where possible, neuraxial block using intrathecal opioid with sedation to reduce long-acting opioid use and to avoid general anesthesia. Local anesthetic infiltration to reduce long-acting opioid use, avoidance of nerve blocks that may result in prolonged motor block and delay in mobilization. Additionally, for colorectal surgery, employ surgical techniques such as transverse incision, mini laparotomy incision, and laparoscopic approach in selected patients. Avoid routine nasogastric tubes and drains. The anesthetic technique should aim to optimize pain control with minimal opioid use. Consider regional blocks, including spinal anesthesia and rectus sheath catheters. Facilitate return to eating and drinking as rapidly as possible post-operatively. Consider TIVA and adequate provision for antiemesis. Ensure appropriate fluid therapy with optimization by cardiac output monitoring. Post-op factors includes use of multimodal analgesia and oral opioids to avoid PCA. Encourage oral fluids early and early nutrition, such as energy drinks. Plan mobilization and physiotherapy. Post-discharge community support or helpline. Additionally, for colorectal surgery, prokinetics such as metoclopramide, and acute pain team involvement and employment of multimodal analgesia. Additional information. Key elements of any perioperative pathway includes prior to surgery, functional assessment, risk prediction and shared decision-making. During surgery, standardized care pathways and best practice evidence-based standards. Early after surgery, enhanced recovery, acute pain management and higher level care provision. Later after surgery, enhanced communication with primary care and increased vigilance for sequelae of perioperative complications. ERAS. Enhanced Recovery After Surgery, ERAS, is the name given to a program that is designed to get patients back to normal health as quickly as possible after major operations. All patients undergoing major surgery should follow an appropriate ERAS program. It is an evidence-based approach to the perioperative pathway that has been shown to improve outcomes and reduce the length of hospital stay. Details of individual ERAS pathways vary depending on the type of surgery and local needs. Examples of pathways are available on the ERAS Society website. Key ERAS principles includes patient preparation and counseling, optimization of nutrition and minimization of fasting times, standardized anesthetic and analgesic regimes, regional and neuraxial techniques to minimize opioid usage, minimal invasive techniques, and reduced use of nasogastric tubes and drains, and early mobilization and enteral nutrition. In an article by Joshi GP et al. In 2023, Guidelines on Preoperative Fasting, the task force reaffirms the previous recommendations for clear liquids until 2 hours preoperatively. Simple or complex carbohydrate-containing clear liquids appear to reduce hunger compared with non-caloric clear liquids. The addition of protein to pre-op carbohydrate-containing clear liquids did not seem to either benefit or harm healthy patients. They suggested not to delay surgery in healthy adults after confirming the removal of chewing gum. Fasting duration is often substantially longer than recommended, and prolonged fasting has well-described adverse consequences. To avoid prolonged fasting in children, efforts should be made to allow clear liquids in healthy children as close to 2 hours before procedures as possible. The task force recommends a robust local effort at each facility, disseminating and discussing information shared in this document, providing necessary education to all patient care teams. It would be necessary to update related policies, printed literature, wall posters and charts to ensure that patients are receiving consistent messages and instructions from all medical personnel. Regarding ongoing care, the surgical team is responsible for patients not requiring higher level care once they leave the recovery area. An anesthetist must be available to review and provide advice to patients with any problems or complications related to anesthesia and related procedures. Regarding enhanced post-op care, centers in the UK are setting up enhanced care areas that provide care between levels 1 and 2 for high-risk patients who do not require admission to HDU but need a level of support higher than that offered in the ward. Enhanced care is a relatively new and evolving concept, aiming to provide higher level of observation, monitoring and interventions than on the general ward. Enhanced advice and support from the critical care team should be more easily accessible. Patients are under the combined care of anesthetic and surgical teams. Levels of post-op care. Level 0, patients whose needs can be met through normal ward care in an acute hospital. Level 1, patients at risk of their condition worsening, or those recently relocated from higher levels of care, whose needs can be met on an acute ward, with additional advice and support from the critical care team. Level 2, patients requiring more detailed observation and intervention, including support for single failing organ system, or post-op care and those stepping down from higher levels of care. Level 3, patients requiring advanced respiratory support alone or basic respiratory support, together with support of at least 2 organ systems. This level includes all complex patients requiring support for multi-organ failure. Thank you.